Combination of minimal prep veneers and some traditional fixed crown and bridge in the posterior to replace some missing teeth. And by minimal prep veneers, I mean that the preparation itself is going to remain entirely in enamel. And you can see here, looking at the facial, that the patient's got some old composites that have a lot of stain around them and some chipping. You can see as we look here from the occlusal view that we have some areas of the teeth that are sticking out a little bit to the facial, like on one of the central incisors you can see it. And we're going to get a better look at this in a minute. You can see where we've got some missing teeth in the posterior and some other work that needs to be done. So rather than doing a full arch of crown and bridge, we're going to do crown and bridge in the posterior, and we're going to do minimal prep veneers in the anterior. And to get a better idea of where we're going to need to do the reduction in the anterior, let's go ahead and take a look at this study model. Here's a look at the preoperative model. The teeth we're concerned with are teeth number 6 through 11, the ones that will be receiving the porcelain veneers. Now, with the advent of no prep veneers and certainly minimal prep veneers, we like to try to prepare the least amount of tooth structure that is possible here. We know that if we can keep most or all the preparation in enamel, we're going to get some better bond strengths when we go to place the veneers. We're going to get less post-operative sensitivity, and we're going to get less debonds down the road. So anytime we can keep everything in enamel, that's the right way to go. Certainly with no preps, we have everything in enamel, but we look at a mouth like this and we can see there's an area here. We're looking for areas that stick out to the facial. These are what we call facial limiting factors, and this impairs our ability to get a good aesthetic result. Namely, we're trying to match the diagnostic wax-up here. That wax-up was done after the lab went and prepared some of these areas. We'll take a look at that in a minute, what the laboratory wants us to do. But as I look at this, I can see there's an area here that's sticking out to the facial. As we look at tooth number 9, I can see there's an area here on the distal. Tooth number 7 looks like it might be sticking out a little bit to the facial, and 6 and 11 look to be maybe in pretty good location. Maybe 11's out a little bit as we look at that. So as I look at this, I'm just kind of planning in my head where we're probably going to need to reduce. The more important thing is where the laboratory thought we were going to need to reduce. So let's take a look at that model. And here's the study model back from the laboratory. This is the areas marked in red where they did some adjustment before doing the diagnostic wax-up. So the diagnostic wax-up was not done on an unprepared model. It was done on a prepped model. And you can see the areas where they feel we need some reduction. And you know what? It's pretty minimal. It's certainly a lot less reduction than the standard way I was taught to prepare veneers. There's nothing on tooth number 6. Tooth number 7 has a small spot in the incisal third on the distal half of the tooth. Tooth number 8, the entire distal third from incisal edge almost to the gingiva, we'll say all the way to the gingiva, needs a little reduction. Then on tooth number 9, you can see the distal half again. Tooth number 10 is untouched. And then just this mesial third, the height of contour on this cuspid, needs to be reduced a little bit. And when you look at the original model and then look where they marked here, you get an idea of how much they reduced. They know that we'd like to stain enamel wherever possible. So all I need to do is go in and make these modifications to these 1, 2, 3, 4 teeth, and I know then we'll be able to achieve the diagnostic wax-up. So once I take an impression of these reductions, the laboratory is going to be able to provide me with porcelain veneers that look like the diagnostic wax-up, which I approved of and the patient approved of as well. So the patient has seen and approved the diagnostic wax-up, and we're just talking a little bit at this point as I point out a few things. And one of the things I tell her we can do, and she wants to do, is to go ahead and show her what the veneers are going to look like in her mouth before we start. You could do this at the prep appointment or before. And you can see here I've got the D-wax, and I'm using a half Hollenbeck to clean up the gingival area. Sometimes on a diagnostic wax-up, these areas aren't that sharp, and you really want to go in here and make sure you define the gingival margin and the embrasures with a sharp instrument like a half Hollenbeck. The temporary technique is going to work a lot better if you do that. So I'm going to go ahead and make that putty wash matrix now for the temporaries, but you'll see I'm going to use it twice. I'll use it before we even start prepping. So we're just mixing up some impression putty here so we can take an impression of the diagnostic wax-up. And then we're going to use our bisacryl temp material to actually give the patient a preview of what it's going to look like. And typically we'll do this at a consultation appointment and maybe not the prep appointment. It all just kind of depends how it falls together. This can give the patient a lot more confidence about how the final veneers are going to look. This can also help the patient decide whether or not they want to commit to the treatment. We've had the patient already pay for the diagnostic wax-up, so we don't end up being stuck with the DWAX and patient not wanting to have treatment. And that's really important because in my career I've gotten stuck with a couple diagnostic wax-ups when I didn't have the patient pay for it. Of course, once the patient pays for it and then has the treatment done, the cost of the diagnostic wax-up is applied to the overall fee. So it's not like it's something that doesn't get used. And as you can see, it's going to get used here, and it's also going to be used for the temporary itself. So the diagnostic wax-up is a lot more than just a sales tool, at least the way that I like to use it. So we place the putty onto the diagnostic wax-up after rolling it into a hot dog, and then we wait until it's completely set. About 4 or 5 minutes. Takes a little bit longer out of the mouth because we don't have the increased temperature of the oral environment, so we let it set, and then you can see I'm using a scalpel here and just carving off the excess where it went down to the land areas of the model. Basically, we just want to go maybe 2 millimeters past the gingival margins, but it's going to make it difficult to put back into her mouth if we leave this huge mass of putty material here. She'll never be able to get her lips down around it, and we want to trim off as much of this as we can just so we can see for sure that the putty wax matrix is completely set. I'm trimming a little bit off the back of the putty matrix here for teeth that are not involved in the treatment at all. It tends to get less accurate when we get back to the soft tissue distal to the second molar. So anywhere we don't need putty, we're going to trim it. And you can see I'm thinning it facially as well here. This just makes it easier to deal with, easier to get in and out of the mouth. We just don't need a huge mass of material. So just take whatever you want, a Bard Parker or a scalpel, and trim this. And now that I've trimmed it, I'm relining it with light body material, and we're squirting that right into the putty matrix, and we're going to reseat this back onto the diagnostic wax-up. And this light body material is going to go into all those areas where we went in and defined the gingival margin and the embrasures with our half Hollenbeck. And we're going to let that set for about 4 minutes till it's set. Take it out. We're going to trim any excess wash material off so that all the wash material we can see is confined to the putty wash matrix itself. And you can see we have a real nice impression of the diagnostic wax-up. Next thing we do is mark the midline, because as you go to put this in place, it gets a little difficult to make sure it's in the right place. You can still do it. It just makes it easier. Then we're going to use some Luxatemp Bisacryl temporary material. And you can see that it's the BL, the bleached shade. On these minimal prep veneers like we're doing on this case, the bleached shade works really well. I've tried to use like an A1, for example, when I thought we were going to do an A1, but these temps are so thin that you see a lot more of the tooth showing through. So in these minimal prep cases, or anytime I'm doing this mock-up that you see here, we always use the bleaching shade to get so that it takes the whiteness of the temporary material and sits on top of the tooth and gives us a desirable shade. You push the putty wash matrix all the way down with the bisacryl inside, just kind of clearing the lip as you see me doing here to make sure that it is seated all the way, and that's one of the reasons why we thinned the front of that putty wash matrix before we started. We've got our midline marker making sure it's in the right place. So we're going to wait a good 3 or 4 minutes here and let this completely set and lock on to those teeth. And what we have here now, we've transferred the information from the diagnostic wax-up to the patient's mouth, and we've got some excess in the lingual I'll take off here, and she can see now what it's going to look like. Now obviously on some areas where the teeth are too facially prominent, we're not going to see exactly what it would look like once the prepping is done. But this is a neat way, especially for somebody with diastemas, to get an idea of what it would look like. It's one thing to look at the diagnostic wax-up, but it goes another level beyond that, where you can actually see in your mouth what it's going to look like with it closed. Some dentists do it with freehand composite. That just takes too long for me to do. And you can see my assistant here using a gold knife to pop this off. Obviously, this is just mechanically retained, and we didn't put any kind of bonding agent or anything on, so that won't stick to the teeth. Here we are using some profound light so that the patient won't feel the needle. On these minimal veneer preparations, it's really up to you and the patient to decide whether or not you want to use any local anesthetic or not. For people who are definitely needle phobic, they usually say, no, let's try it without. We use a lot of light pressure with a new diamond, very coarse diamond, so we take off as much tooth as we can and don't generate a lot of heat. But this patient is not needle phobic and wanted to have anesthetic, so she didn't have to worry about feeling anything, and that's fine with me. Here's a look at the prep guide model from the laboratory in comparison to the teeth we have here. And I always kind of hold this here and just get an idea once I'm looking at the teeth of where I need to reduce. And a lot of times my bracket table sits right over the patient's chest, so you can either set the model on the, I suppose, the patient's chest if you wanted to, or probably better on the bracket table, so you can look and refer to this as you make these markings. You know, it's just an approximation as you look to see how much the lab is reduced as you go in and reduce this from the tooth. And again, you can see me using a large diameter burr. This is going to reduce a lot of tooth structure at one time. It's going to be nice and smooth on the tooth. The thinner the burr you use, the more the burr wants to kind of dive into the tooth and create grooves. And all we're trying to do here is eliminate those proximal line angles and the portions of the tooth that are sitting facial to our ideal arch form. So simply follow the model. You know, if anything, I suppose you're going to want to reduce just a little bit more than you see on the model. Laboratory technicians never complain about having too much room. I can tell you, because I spend my whole day with laboratory technicians, the only complaint we hear from them is not enough reduction. You know, so it depends on how the patient feels. Technicians understand on a no prep case, you know, that they have to work with what's there. They're not always happy about it. But on these minimal reduction cases, you know, where we're kind of going in and guessing just a little bit, basically it's a matter of taking off the tooth structure and looking at the prep guide model and seeing if you've eliminated that. Oftentimes I'll use a photo mirror that I'll put in place and actually use the photo mirror to look down from the incisal edge of the tooth and see if I'm eliminating those facial limiting factors. And in addition to the minimal prep veneers, which is the focus of this case, the patient also at the same time wanted to have some fixed bridges done on her posterior teeth to eliminate some spaces she had. So we'll briefly go through that. And there's that round burr, the 801-021 burr that we use as part of the reverse preparation technique. And that's really a great look because we don't have an adjacent tooth at what that round burr does. You can see it really is creating not only the gingival reduction, but the margin at the same time. And so in a case like that where you've got a tooth out in the middle of nowhere with no adjacent teeth, we can actually use that round burr all the way around those teeth. Here we are putting 2 millimeter depth reduction holes in the top with the MADC 020 burr. If I don't put these 2 millimeter holes in this teeth, I can almost guarantee you that I will not reduce 2 millimeters. And that's after being a dentist for 20 years and thinking I know what 2 millimeters looks like. It's just part of human nature that once you start to reduce a tooth with a diamond, you can never really tell how much you've reduced. And most of us, being conservative by nature, try to prep the least amount possible to get the desired result. The problem is oftentimes we don't get the desired result when we get the restorations back from the lab because we have not in fact reduced enough. So we put 1.5 millimeter holes in the axial surfaces. And again, my favorite burr right there, the 856-025, that big round bullet-nosed burr that I use for almost all the reduction once I've done the round burr and broken the contacts if necessary and placed the depth cuts. Almost everything else is going to be done with this 856-025 unless it's an anterior tooth, and then we'll go ahead and use the football burr on the lingual surface. But these are posterior teeth, so you can see once I have the depth cuts in, I'm go ahead and I'm making cuts down to the level of those depth cuts, those 2 millimeter holes I put in here with that 856-025 burr, working it back and forth. And I love this burr. It's such a great workhorse. It's a nice coarse burr, does a good job of cutting through, does a great job of refining the margin as you go down to blend the axial planes and combine your other depth cuts with the gingival depth cut that you originally did with the round burr. And I love its big diameter. It sits well on the tooth. I just think this is, if you told me I can only practice with one burr for the rest of my career, I think it'd have to be an 856-025 like this. Just extremely versatile, can do almost anything with the exception of lingual reduction on anterior teeth. So again, once we have all the depth cuts in place, it's pretty much just a race against time to see how quickly we can get the rest of the tooth structure off. And these preps are starting to take shape now, and just going around and blending some final planes here on this bridge on this one side. We're leaving that buccal margin supragingival, as you can see here. That's not a critical aesthetic area. The patient's had some recession over there, and really no reason for me to drop that all the way down to the gingiva and get a long, long wall for that bridge. That's going to be a little more difficult to seat, a little more difficult to avoid undercuts, and all those kinds of things. And I know if I give my laboratory technician a nice supragingival margin and get a good impression of it, we're going to get a great looking margin over, and it's going to be nice and closed. And since it's in a non-aesthetic area, I don't see any reason to go down any farther. We're taking the biotemps that the lab has fabricated for us and just trying those on over the bridge to assure that we have passive fit here. And you can see we do have passive fit. In fact, it rocks around a little bit, which is fine because we're going to go ahead and reline that in just a minute. But first, we're going to take a bite registration before we prepare the posterior teeth on the other side. So we're squirting bite registration just onto the prepared teeth and then having the patient close all the way down into maximum intercuspation, squirting a little extra bite registration material there. You do not want to take a bite registration of the entire arch for a case like this, just on the prepared teeth. This is the capture bite registration material. The hard bite material sets in about 60 seconds, and we can pop that out. And it'll be trimmed back by us or the laboratory so that only the occlusal third of the preparations are sticking into the bite registration, and only the incisal third of the occlusal third of the opposing teeth are sticking into the registration as well. We've now relined this with our acrylic material, and we're pushing it down into place on the preparations, and this is when these temporaries are really going to fit well afterwards. And this is one of the great uses for biotemps. That's a really nice looking provisional bridge, very strong. It's got wire reinforcement in it, made from hollowed out denture teeth, so it has some very nice aesthetics as well. And we push this down into place and wait for the acrylic to go through its reaction as we pump it up and down to avoid any undercuts that might be there. Doctors often ask me, can I use bisacryl inside of biotemps like that? And I can tell you that while chemically there's no bond between the bisacryl and the biotemp material, I have found it to be a procedure that works well. The only difficulty is, and you can see we're starting to prep the posterior teeth over on the other side using the same reverse preparation technique. We do have a DVD that it's available for viewing online at glidewell-lab.com, the reverse preparation technique. Or we'll send you a copy of the DVD if you'd rather watch it that way. And those are the principles that we are following here. But back to the bisacryl, even though it doesn't bond to it, the bigger danger with the bisacryl when using it inside biotemps is that because it doesn't have a doughy stage like acrylic, you can lock it onto the teeth. And as a result, there's no pumping it up and down. As you know, when you put the bisacryl on the inside and it goes to its full set, if you've got undercuts on a tooth, you can lock it in place. If you have undercuts between teeth, like on the bridges we're prepping here, you can lock it on as well. So it's important to make sure that you use the acrylic when you've got these multiple unit biotemp situations, unless you're absolutely 100% sure that there are no undercuts either on the teeth or either between the preparations themselves. And if you're totally assured of that, then you can go ahead and use the bisacryl if you wish. The acrylic sets up harder, I think is less porous, and if the biotemps restorations are going to be in for a while, it's a better idea to use the acrylic. We're now trying in the biotemps and checking for passive fit on the other side. You want to make sure that the margins are down all the way as well. Obviously, we're going to reline it, so if we had a margin or two that was short, it's not going to be the end of the world. But typically, if there's a margin that is short and you haven't done anything there, you can see how it just rocks into place right there. That might be the case. So the biotemps go in after we take a bite registration over there, and the patient comes back 2 weeks later. And this is the appointment here. We're going to go ahead and take an impression for both these bridges and for the minimal prep veneers in the front. You can see we've cemented the bridges with Duralon, and I'm using my Cabo sonic scaler to get the Duralon off the teeth, and it flakes right off with the sonic scaler like this. Obviously, the patient is anesthetized since this is the impression appointment, and Duralon is just the greatest temporary cement in the world. You will never lose temporaries. You won't have any sensitivity. The cement is just as snow white when you take off the temps a couple weeks or even a couple months later, because there's just no absorption of bacteria underneath it, no leakage. It's a great antibacterial cement. But if you don't have a sonic scaler like this, it's a real bear. In fact, it's almost impossible to get the Duralon off by hand. So you need to be careful and make sure you have a sonic scaler before you begin to attempt something like that. And now we're going to go through our 2-chord technique. This is the first chord, the bottom chord. A double 0 chord that goes into place first. This sits at the base of the sulcus. And this is the chord that's going to ensure that we don't have any bleeding when we pull the top chord out. So this chord is not primarily responsible for displacement of the tissue per se, even though it does displace the tissue a lot. Its ultimate goal is to ensure we don't have any bleeding when we take out the top chord, the larger chord, the number 2 chord, which is the one that's responsible for most of the retraction here. On no prep veneers, we don't place any retraction cord, but on these minimal prep veneers where we've removed some tooth structure close to the gingival margin, we're going to go ahead and place some retraction cord around here. You can see the 00 cord being put into place and cut short. We want to make sure we tuck the ends, the free ends of the 00 cord into place so that we can assure that we don't pull that out during the impression process. We don't want it embedded in or around the margin of it. So we want to make sure that the ends of that 00 cord are completely subgingival. Now my assistant's placing the number 2 cord, the top cord, into place. Here in California, either she can place the cord or I can place the cord. She's got her extended function license, which allows her to do that. So one of us will put the number 2 cord in and put a comper cap on top of that, have the patient bite down. We wait 8 to 10 minutes, remove the top cord, and you can see the capture medium body material being expressed around the abutment teeth in the back, being expressed around the minimal prep veneer teeth in the front. Want to make sure that we get that whole facial surface, everything that we've prepped, and then around the bridge abutments in the posterior on the other side. And then you can see we are inserting a custom tray into place on the upper for this impression, a paletless custom tray. And the reason we do that is reduces gagging, makes it a lot easier for the patient. We use a lot less impression material when we use a custom tray, and the fit of the tray is always perfect. And that's a nice thing to know as you're putting the tray in there. We're not going to impose on any tori. We're not going to run into the tuberosity. You just know a custom tray is always going to fit. It's well worth whatever your lab charges you for it. And here's a closer look at that upper impression after it's taken out after about 3.5 minutes, and we've got nice definition around the bridge preparations in the posterior and nice definition around the minimal prep veneers in the anterior. So here we are at the 3rd appointment. This is the cementation appointment and the bonding of the minimal prep veneers. We're taking off the biotemps in the posterior. Biotemps really hold up well over the long haul. You can take them off many times. There's been a lot of cases where we've had them on and off several times over the period of 6 months while we had some periodontal work done or while we had some hygiene appointments. I love having my hygienist be able to do hygiene while the preps are done because they can really get in and get everywhere and really make sure that things are nice before we take our final impression. So we clean off the excess Duralon cement here with our sonic scaler again. We try the bridge in. Everything fits fine, so we're going to go ahead and cement this bridge. And that cement, if you don't recognize it, I don't know how much you can recognize a Crown and Bridge cement, but that's Reliax Luting Cement Plus from 3M SB, just the greatest resin-reinforced glass ionomer cement around, at least in my eyes. It's just a fantastic cement, great natural bond strength to the dentin of the tooth, low to no post-operative sensitivity, very easy cleanup, easy to mix. Everything's great about it. There's the bridge on the other side, going in with that same cement with the Reliax Luting Cement. Pushing that into place and now cleaning it up. That's my assistant cleaning it up. You'll be relieved to know that I do not wear pink gloves as a fashion statement. So once that cement is completely set, she can clean that up, and then we're going to run some floss threaders underneath those bridges and make sure we have in fact removed all the excess cement. And once that is done, we will move up to the front and begin bonding the minimal prep veneers into place. And the first step of bonding the minimal prep veneers into place is to clean up those teeth. We do this with no preps too. We do this with really any prep, but sometimes dentists don't think you need to do it on a no prep because you haven't prepped. But those teeth always have that salivary plaque, and we just want to get a nice bond to it. So we're going to use the pumice. As you can see, this is from Preppies, the Whip Mix product, the prepackaged pumice, and then we're using a brush just to make sure that we have all of the pumice off the teeth. I find that on these minimal prep veneers they actually get dirtier than no prep because the surfaces of the teeth are kind of rough where we've done some reduction with the diamond itself. And we always start our try-ins on these veneers with the translucent shade of the Variolink veneer cement. And the reason we do that is the most neutral shade that we have, and it gives us a good idea of whether or not the veneers and the cement is blocking out the underlying tooth colors of it. And as you'll see on this DVD with these thin veneers, the minimal prep veneers and the no prep veneers, they actually are shade adjustable. So you can use different shades of try-and cement, as you'll see later on this DVD, to give the patient different looks. But we always start with the translucent shade because I think it's the most natural shade of the cement of all the different cements that we have. So the patient looks at it with the mirror. She approves. If she said, I think it looks too dark or I think it looks too white, then we would have gone to a different shade Tri-N cement. So once we've done that, again, using the brush with some water to get the Tri-N paste off the teeth because it is water soluble. It likes to hide in between the teeth, so we're using some floss just to make sure we get all that non-setting Tri-N cement off of the teeth. And now we can go ahead and begin to etch the teeth. When I call these minimal prep veneers, to me that implies that all the margins and all the surfaces that we're bonding to are within enamel. So we're going to go ahead and etch these teeth for 15 seconds. Rinse that off. Place our bonding agent. Now, just like with the no prep veneer, the bonding agent here is the old school bonding agent from a 2-bottle system. And instead of using the primer, we're just using the adhesive. And because we have no exposed dentin, that's what we're doing here. We've painted that on. I'm using a little air just to kind of thin that so we don't have any pools of bonding material anywhere on the tooth. With a typical dentin bonding agent, we would be using the air to evaporate the acetone. But here I'm actually using it to kind of physically thin that layer of the adhesive from the 2-bottle system because it is a little thicker than even a dentin bonding agent would be. We're always going to start with tooth 8 and 9. I mean, the smile is, here's where you make it or break it with these first 2 veneers. So I always put these 2 on separately. You know, if I'm ever in a hurry, I still put them on separately. And 8 and 9 are always going to go on first because if these 2 aren't right, it doesn't matter what the rest of the smile looks like. Things will be messed up. And you can see that's the translucent cement. It looks a little yellowish as you look at that, as you look at the shade of what that cement looks like, but it's not. It is translucent. In fact, if you take this cement and squirt it onto a newspaper, you'll find that this Link veneer translucent cement is one of the only cements that is truly translucent that you can see through. In fact, that's how I ended up using this cement. We've looked at several other brands of translucent cement, and they're really not all that translucent, which is kind of surprising, but they seem to have picked more of a neutral color than a translucent one. You can see my assistant with the LED light just going around giving half-second, maybe full-second cures, but usually half-second cures in different areas, so I can go around with the Explorer and clean the excess cement off. This is the place to do it. I know there's clinicians out there who like to bond or the entire veneer in at this point and then use strips to cut through it. I prefer to do a little bit of bonding here, a little bit of bonding there, as you saw in the gingival, clean all that up, then try to get floss in between the teeth. If that won't go through, I'll take one of these ribbon saws that you can see here and go between it. And if you've cleaned enough ahead of time, the only thing you should be getting out between the teeth is bonding agent. It's really not difficult to get through unless you've actually bonded veneer cement in between the teeth. Then you are going to need to spend some time sawing your way through that contact. Again, we're just going to place the next 2 veneers simultaneously. This is typically how I do it. Even if we were doing the bicuspids as well, I would put these 2 on and then move on to the next one. You know, putting 4 veneers in place at the same time is a lot different than putting 4 crowns in the same place at the same time. I mean, you really might be able to place multiple units of crown and bridge because of the fit that they have on the tooth. The mechanical retention as it slides down over the preparation. And that's just not true with the veneers. You know, as you put these into place, in fact, many times when you'll try them in, it'll look like they all fit, but in fact, you have contact issues here and there. So we're going to place those 2 veneers, and of course, our fixed bridge is right behind that. Then we move to the other side, to teeth number 6 and 7, and we place those 2 veneers, going through those same steps with the pumice, rinse, the acid etch, the adhesive. The veneer goes into place with the translucent cement, and we cure that slowly as I clean up the excess cement. And then we're using a brownie, as you can see there. The brownie is a great way to get cured cement off the facial of a porcelain restoration without scratching it up. I love those brownies and greenies for that. The best way to clean up these veneers without doing any damage to the porcelain. That's a 7408 carbide burr that we use to clean up the lingual margin. There's always some excess there, sometimes a little speed bump of cement right where the veneer and the tooth come together. And I love that 7408 to go in there and blend that lingual junction between the veneer and the tooth itself. Then we're using a pointed bristle brush just to make sure we've gotten everything out from the embrasures itself. And you can see some super floss. There is that area that looks like a little soft pipe cleaner or a caterpillar, and we go through with the floss and then take that through, and that grabs little pieces, as you can see there, the regular floss didn't get. And there's our patient's first smile after we've cleaned up the excess cement with the minimal prep veneers in the anterior and the fixed bridges in the posterior. Pretty difficult to make restorations in the posterior that look as good as those minimal prep veneers. So we were able to stay completely in enamel in our preparations, which is nice. We have a better bond to the tooth itself. We have less postoperative sensitivity. Just all kinds of reasons for doing that. And here is our portrait picture of her smiling at the end. A very nice result with the use of the minimal prep veneers in the anterior, showing that we don't necessarily have to go in and prepare these teeth for crowns, even though we're doing crown and bridge in the back. We can get a very satisfying aesthetic result with the use of minimal prep veneers. This next case is a no prep veneer case, and it's one that I'd like to use to show you what shade adjustable veneers look like, the thin press veneers. There's a certain ingot we use, and we're able to make these veneers pretty translucent, and I was a little skeptical as to how well that this might actually work. You can see on these befores we've got some spaces in between the teeth, which of course are the perfect no prep cases as long as they don't have any major facial limiting factors, and she doesn't have any facial limiting factors to speak of, but she does have spaces in between her teeth, and those are the people who always do really well with no prep veneers, or people with short teeth who desire to have slightly longer teeth, because we do of course always get an increase in the length. We always get an increase in the bulk as well, but sometimes that's offset by the look of the length. As the teeth get longer, they are allowed to get wider and still have the proper width to length ratio. And so when we're closing spaces, we almost have to add length to make sure that we don't throw off that width to length ratio of 75 to 80% for the average central incisor. This is the medium value or translucent try-in cement in the VarioLink veneer system from Ivoclar Vivadet, and this is the one we always start with. We always try this in first because it's the one that looks the most natural, I think, because it doesn't have a lot of color in it. So, but on this case, we're also going to use the low value try-in cement. So this would be for, if you had a patient where you tried in the veneers with the translucent and they thought it looked a little too white, a little too Hollywoodish, a little too fake, whatever word the patient might use to communicate that to you. And that's what those 6 veneers that we're trying in. We have bicuspid veneers as well. We're just trying in these anterior 6. These are the ones that are the easiest for you to see. So you can see the difference in what this looks like with the low value cement in place. And at the end of this, we'll show you what it looks like with all of these in place. So here's a look at how those veneers look with the low value cement in place. Definitely not as white, not as high value as with the translucent cement. And this is the VarioLink veneer try-in high value cement. So if you tried them in with the translucent and the patient thought, boy, I thought my teeth were going to be a lot whiter, this is where you would go to this cement. And you can see, on most of these, you can see when the excess of cement is out there, what we're looking at in terms of cement color. You can see, exactly what we have. And, we've done experiments before here at the lab where we've taken these veneer cements and we have put them between 2 glass slides. And when they get really thin, they all become almost translucent. But the reality is that we have found through this patient and many other patients that when you put these under veneers and put them on the teeth, you can, in fact, see a difference when we're using this shade adjustable porcelain. And as you look at those veneers tried into place with the high value cement, you should be able to notice that we definitely see a difference between that and the bicuspids behind it. And so here's a look at all 3 of those from top to bottom. That's the translucent on the top, that's the low value in the middle, and the high value at the bottom. And those are all the same 6 veneers, but because of the translucent effect of these veneers and because of the fact that they're only 0.3 of a millimeter thick, it gives you and the patient the ability to try in multiple shades and see which one the patient likes better. Now, if you try in the translucent shade, the medium value shade, and they're happy with that, you may just want to go with that. But here, my assistant is we placed number 9, 10, and 11 with the high value, and here's the low value on 6, 7, and 8. So you can see the big difference, and that's the same set of veneers. Look at the difference in shade between the 3 on the left and the 3 on the right, and I love this. I love having the ability to dial in this shade according to what the patient thinks at chairside. I mean, oftentimes with prep veneers, they're so thick you can't influence them with different shades of veneer cement, even though you might think that you can. With these thin, more translucent veneers, you can, and it gives you the opportunity to let the patient really decide, chairside, which one they like best. Again, we usually start with the translucent, and if we like that and they're happy with it, we go from there. But if they say, I thought they might be a little bit lighter, then we'll try something like that. And of course, you could even mix the cements. You can mix half translucent and half high value if you're looking for something in between. The patient, believe it or not, selected the low value one. She liked the one that she thought looked most natural with the low value. So as we pumice the teeth here, again, this is the preppy pumice, the prepackaged pumice from Whitmix. We're actually going to be using the low value here, which doesn't happen all that often. Usually people are looking for something like Hollywood white, or we think that's what they're looking for. And I've seen more patients recently be very happy with either the translucent shade, and seen a couple patients, 2 women included and several men, who like the low value better because it looked like a more natural tooth and didn't look like something that screamed out, kind of veneers, and I think we've all seen cases like that. I think most of us are happier doing work that looks more natural. Of course, we want the patient to be happy at the same time, but we love doing work that looks natural, and that becomes more challenging as the value of the veneers themselves gets higher and higher. So we've etched number 8 and 9 for 15 seconds because this is an all enamel surface because it's a no prep veneer. And then we remove that and we paint the adhesive on from a 2-bottle system. This happens to be from the Scotch Bond system. And you can see as we place the veneer on tooth number 8 in, if I move my mirror, you'll be able to see that we've got that low value cement. You can see how yellow that is. It comes out from under the veneer. There I am with my orange wood sticks. Boy, it seems rare that I ever seat anything without a couple orange wood sticks in my hand, especially veneers. I'm really impressed too. You'd think that you have to really treat these 0.3 millimeters with kids' gloves, but you can see me pushing down facially and on the incisal to make sure these are sat all the way with these orange wood sticks, holding it at the incisal edge to make sure the incisal edge lengths are the same. And I'm not saying you can step on these veneers or have the patient crank down and bite on them, but you can use these orange wood sticks to push down on them a little bit. My assistant cures that for a second and a half. We clean that up. Anywhere where it still looks like the cement is just a little bit runny, she'll come back in and cure for another half second or second. And we just slowly work our way and remove all the semi-set or gel state cement around from the tooth using kind of a tack and wave technique, if you will, where she holds the light couple millimeters away and tacks it into place. Again, with no prep veneers, we're not pushing these down onto any margin per se, so that's why we use the orange wood sticks to kind of make sure it's down all the way facial, down all the way incisal, and we get an idea that these are in fact in the right place. Once we've done tack and wave, we begin to cure it interproximally and clean interproximally. If we can go directly in with dental floss, we will do that. If we can't get in with dental floss, we'll use one of these little ribbon saws from Access Dental that you see me using here. It's serrated on one edge and it'll break through anything that's there. And now you can see the glide floss going in between there easily, and that is in fact our goal, to make sure that floss will go through there. Oftentimes you'll have bonding agent cured between those two teeth, and you just need to go through with that ribbon saw first to make sure that you'll be able to get the floss in later without snagging it and getting floss caught in between the teeth. If you do an exceptional job cleaning up during the tack and wave stage, you may be able to go right to the floss and get that through. There is a knot in that floss because without it, it's very difficult to get cement out of the embrasure, so we do have a small knot in there. And again, we're rinsing off the acid etch from the teeth, and then we're going to place the bonding agent. And then we will air thin that bonding agent. Again, this is not your typical Denton bonding agent that we're used to using so often, whether it's for prep veneers or direct composites or things like that. This is the old school bonding agent, the 2-bottle system with the primer and the adhesive and just the adhesive. It's funny, for a lot of us, it's been a lot of time since we've bonded to just a straight enamel surface, unless we're doing just like a little class 4 composite on an anterior tooth. But that's exactly what this is like. We're bonding to enamel. It's fun to bond to enamel. We get to rinse off the acid etch and dry the teeth without having to worry about over drying the dentin or anything like that. And here are those veneers in place. And you can see by closing those spaces just what a great look, what a great improvement in her appearance from the before on the upper left to the after on the lower right. Anytime we close those spaces, we get that instant improvement. The eye is drawn to those dark spaces. If we have nothing but the pink of the gingiva and the white of the tooth, The eye is really not drawn to anything immediately. It's those dark spaces in between the two where all of a sudden the eye is drawn there, and the patient's eyes are drawn there as well. In fact, she commented as we were taking these after pictures that she wants to do her lower ones because you can see she's got some space down there as well, and so that would probably lend itself pretty easily to either a no prep or a minimal prep case as well. I'm going to show you a minimal prep case as well, and this is interesting because the patient came in having heard about no prep veneers, seeing an ad on the back of a magazine. And I had to talk to her about why this was not a suitable no prep case. You know, don't get forced into doing no preps if you don't think it's going to work well. In fact, it's those kind of cases that give no prep veneers a bad reputation. And you can see here as we look at the occlusal view of these teeth why this is a horrible no prep case. And you can see how the distal surfaces of tooth number 8 and 9 are both rotated out to the facial. And you can see how those teeth are kind of looking like a butterfly the way they've rotated out. And there's just no way. Now, granted, on the mesial half of those two teeth, you could do no prep veneers, but the distal half is only going to get worse. And to get proper arch form back to teeth number 7, 8, 9, and 10 here, we're going to have to do some reduction on the distal thirds of tooth number 8 and 9. There's just no way about it. So she came in for a no prep veneer, and we had to have a talk about minimal prep veneers. We just need to go in there and reduce some of the distal third of those teeth. And when she saw the model and saw it from the incisal and saw her occlusal picture, it became obvious to her as well we were going to have to do that. And you can see on this right lateral view there's an old composite there on that central incisor. We'll have to see how that comes into play as we go to reduce that. And this patient does not like needles, not that any do, but she requested no anesthesia. That's one of the reasons she wanted no prep. So I told her we're just going to go really slowly and recontour the surfaces of these teeth. So you can see the burrs going on the tooth, off the tooth, on the tooth, off the tooth, on the tooth, off the tooth. Trying to keep the tooth cool. Nice, lots of water being used here. Got the water turned up all the way, trying not to generate any heat whatsoever. And here we are smoothing out those preparations with a fine grit diamond. We're not going to make any temporaries on her, and so we want to make sure that we have a nice smooth surface so it's not getting coffee stains and all kinds of stains like that. So we've used the prep guide from the laboratory and compared our preps to that to make sure that we have in fact got what we're looking for in the desired amount of reduction here. Any amount of reduction is going to make this case better. You know, we'd rather get as much reduction as we can and keep it in enamel for the sake of the patient, for her not wanting anesthesia. But any amount of reduction is going to make this better than it would be had you decided to go ahead and make this a no prep case. We're going to go ahead and making sure the teeth are still nice and well hydrated and take a shade here on those adjacent teeth. And as I take a shade here in the middle third to get a nice base shade, it looks like we've got a D2 here on that one tooth. And take that in the middle shade, and then we'll go to the cuspid, the tooth behind it, and see what kind of shade that we get on this tooth as well. And it's not enough just to take those shades. We want to take those shades and then take pictures of those shade guides next to those teeth in the mouth. And by doing that, we're able to ensure that the laboratory knows not only what the easy shade told us the shade of the tooth was, but what that shade tab looks like in the mouth. And that's critically important for them to be able to see, because sometimes the tooth matches closely to a shade guide, but not exactly on it. And we're going to go ahead and express impression material around here. We didn't do any preparation by the gingival third, so we're not packing any cord here. And then we're going to place a tray into the mouth with the heavy body material in there. Pull the lip down over it, make sure it's seated all the way. Wait the 3 minutes for the impression to set completely. And remove this, wiggling this out like that. Remember, on alginets, materials like that, you snap them right out of the mouth. And we're going to wiggle this out of the mouth and let that elastomeric properties of the material, if it's stuck anywhere, let it kind of disengage from any undercut that might be there. And that's about it, since we're not doing any temps. So we're already on to the next appointment here, where we're trying in these veneers. And by now you should know that we always start with the medium shade or translucent try and cement with the Variolink veneer system. I still find that's the best place to start to see what we're going to look like when these 4 veneers are in place. So we're pushing these veneers into place. And I can tell already just looking at the try-in that we've certainly been helped out by doing some preparation on the distal thirds of those teeth. If we hadn't done those prep veneers, we would have things that were sticking out really far. In fact, it would probably accentuate the facial limiting factors of those distal thirds sticking out past that ideal arch form. So patient's given a mirror. She likes what she sees, and so we can go ahead and begin to place these veneers by cleaning the teeth off with some pumice. That's Preppies, and now we're going to go ahead and etch 8 and 9. And even in a case like this, even in a case where we are placing only 4 veneers in place, I still always just place 8 and 9 first. It's just too crucial to get these teeth right, and there's no reason to try to rush through this, especially when you think about all the time you saved on having to prep all these veneers, having to temporize all these veneers. There's a little extra time that we have on this appointment to go slowly and make sure that we get it right. We wait 15 seconds and then rinse the etch off, and if you're all in enamel, it's just like bonding to enamel where you can dry as much as you want, and you don't have to worry like you do with dentin about making sure that you leave it moist. And that's one of the nice things about these minimal prep veneers and bonding to enamel. We now place the bonding agent, and since our margins are all in enamel and so is the whole surface that we're bonding to, this is the adhesive from one of the old 2-bottle systems. I hope you have some of that laying around unless you've been doing nothing but dentin bonding for a while, but you should have some of that for doing, small anterior composites and things like that. So once we put that on, we air thin it, and then we actually cure that into place, and now the veneers are going in. And that is the translucent cement. I know it looks a little bit yellow, but it only looks yellow until you see the yellow. That is, in fact, the translucent cement. And then we're going to do a little tack and wave with a cure for just about a second, maybe a second and a half. And that's what we want to see, a huge piece of cement come off in one big piece like that from around both those facial margins. I always start with an Explorer, and most of the time I can get it off with the Explorer. If it's a little overcooked and a little overcured, I'll go on with a scaler or something a little stronger, but there's more potential for me to fly into the gingiva and do some damage. So I always try to do it with the Explorer. I'd almost prefer, rather than overcure it, to go check an area with the Explorer and have it be undercured and have my assistant come back for another second or two. And typically once we've done that, we cannot get floss in there. I didn't even try on this one. I'm just taking this saw, just 1 or 2 swipes with this ribbon saw and going through the contacts with the serrated strip to get out any bonding agent or to get out any veneer cement that might be in there. It's crucial you remove that too, not only for the periodontal health, but just be able to get the lateral incisor veneers in place as well. So once we have it all cleaned up, we can do a final cure and then go through with floss with the knot in it to make sure we have, in fact, removed all that cement, because a little extra cement there on the lateral incisor, for example, would make it really difficult to get that veneer on. And that's why I don't etch all the teeth at the same time. Dentists have asked me before, why don't you just etch all the teeth at the same time? Because when you do that, when you're placing on 8 and 9 by itself, if you get some cement over on an etched tooth, even though there's not bonding agent, it does stick there a little bit more and it's difficult to keep it clean. So we just etch the teeth as we bond them so that we never have any unetched teeth. And in this shot here, you can see the different sequence that we already went through with the central incisors of etching, rinsing, drying, and putting on the bonding agent. And now all 4 veneers are bonded into place. And here I am using my second favorite burr, this 7408 carbide burr, to go in and smooth the junction between the tooth and the veneer where the excess cement is. Once we have that clear, we have the patient bite down so we can check and see how we're doing back there. Make sure we don't have any extra spots. And we always hit it with this brownie wheel. Love the brownie wheel. Just no better way to get set veneer cement off a glazed facial surface of porcelain than with this brownie wheel. It's a great way to be able to get the cement off without causing any damage to the porcelain or the glaze. Last thing you want to do is take like a carbide burr or, God forbid, a diamond to the front of these veneers and do that. So we want to use something relatively benign to get it off. You could also use composite polishing wheels. You don't have to go out and buy the brownies and greenies. I just happen to like them. But if you had some composite polishing wheels, those would take the composite off the porcelain too without scratching or scuffing or doing anything to the porcelain. And then we take our little bristle brush in a slow speed handpiece with a bunch of water and making sure that we're clean everything off these veneers as we're getting the patient ready to leave at this point. And then we usually always throw in a final cure We all grew up thinking there's no such thing as over-curing. And we've got a nice look. There you can see it right there, 4 veneers that look pretty darn natural, considering that we didn't have to do any major gingival recontouring or anything. For a patient who wanted no prep veneers, by informing them that we did need to prep the distal thirds of both those teeth, we end up with a much better result. I can guarantee you that had we done this as a no prep case according to the patient's desires, that this case would not turn out looking as good as it does. Those central incisors would be much more prominent, especially on the distal, and the laterals would have to be bulked out even more to try to make it look like it was in an ideal arch form. So there are times where, you know, the patient, just because they come in for no prep veneers, they can't be the one to decide, okay, this is going to be a no prep case. What would have happened if she would have refused to have the no prep veneers and said, well, then I'll just go somewhere else and have the no prep veneers done? Well, after 20 years of doing this, I would have been more than happy to let her go. I've learned the hard way not to try to do things I think's not going to work just because the patient thinks it's going to work or they saw an advertisement on it on TV. So a good example of how somebody came in for a no prep case and we made it a minimal prep case and ended up with an aesthetic result that we were really happy with and the patient was. These veneer cases, you'll know that I always say that the best no prep case is when you have spaces in between the teeth, but we've got a big diastema here between number 8 and 9, and we've got one behind the cuspid between tooth number 5 and 6, and as you look from the occlusal, you can see actually that's a space that we have bilaterally between the cuspid and the first bicuspid. A lot of times you'll see it between the cuspid and the second bicuspid when the first bicuspids were removed during childhood for orthodontic purposes. But you can see between teeth number 8 and 9 where we have that huge space, and we don't really have any facial limiting factors here. Tooth number 7 is just slightly rotated to the distal, but tooth number 10 is as well. So this is not real dramatic, and this is actually a pretty good no prep case. The biggest problem is going to be closing that space and getting some additional length so the teeth don't look too square. So we've actually already had the veneers made. We've tried them in for the patient. We use these shade adjustable veneers here and tried it in with the different ones, and the patient actually liked the low value one. The second one on this DVD, the second patient liked the low value one because he thought it was a more natural look and felt that they looked a little too bright with even the translucent, let alone the high value, which we didn't even try in. So it actually looks good, as you'll see here as we place these veneers into place. We haven't shown the try-in just in the interest of time, because you've seen us do another try-in case here with the different cements and what it looks like. So you can see me tracing around the gingival margin here as we bond tooth number 8 and 9 in first, and it's nice to be able to take the acid etch right up to the gingival margin. It will not cause any damage to the gingiva since it's only in place for 15 seconds, but if this were a prep veneer case and we had just taken the temporaries off, that acid etch in contact with the gingiva for 15 seconds would have almost undoubtedly caused bleeding because of the irritation of having the temporaries on during the week or 2 week provisionalization period. Getting the acid etch against the gingiva is all that it takes for the gingiva to start bleeding in many cases. And this is one of the things that I like about no prep and minimal prep veneers compared to the typically prep veneers, is the ability to not have to worry so much and the comfort of not having to worry so much about spontaneous gingival bleeding during, say, this stage right here. Say you etched, got some against the gingiva, rinsed it off, and as you're placing the bonding agent, all of a sudden you get some gingival bleeding. You're going to get contamination of the surface and have to start all over again. And if it happens at the point where you're curing it here, then you're going to have to prep the bonding agent off or just go for it and try to get the veneer into place and stop the bleeding. So it's definitely one of the tricky things about bonding prep veneers in that we don't see with minimal prep, no prep, or crown and bridge for that matter. Again, you can see the low value cement here, how yellow that looks compared to the translucent that we've been using. And here I am again with the orange wood sticks pushing down against the facial surface of the tooth and against the incisal edge. I like pushing in both directions at the same time, as you see here, to make sure that it's a nice firm contact with the tooth below it. Now these no prep veneers won't exactly float around in space, as it were, but because there are no margins we're pushing against, we do have to make sure that they are down. It is possible, if you only push from the incisal, to move the veneer away from the tooth, and if you just push from the facial, to have the veneer slide down. So I push both ways Then typically I'll hold the veneers down as you're seeing here with the orange wood sticks and have my assistant cure for about half a second and then go ahead and check. And if it still feels a little bit rubbery, have her cure for another half second. Well, I hold the veneers in place. And again, I'd rather she undercure the material than overcure it. If she undercures it, as she did here, she can come back in for another second or so and cure it. That was a long cure. Let's hope this isn't too set. And look at that, still a little bit soft. So we're going to have her cure a little more. One of those weird humidity days in my operatory where we need a little more light cure to get it done. And it's actually not so much the humidity, but it's the fact that it's the low-value veneer cement. The low-value veneer cement does take longer cure time than the translucent does, I guess because of the pigment that's in the cement. I couldn't tell you for sure, but I have noticed over time that as we've used this low-value cement, it does take a little bit longer on this tack and wave. But you can see it's set now, and I'm just sliding the Explorer around, being careful not to poke it into the gingiva. We still don't want to get any bleeding here. You can see right there, still a little gooey on the distal, so she's going to cure it a little bit longer than we usually would. And there we go. That's now set. And we're just kind of trying to trace our way down to the gingiva, and that's what we want to see. One huge piece of cement come off like that. And then we just kind of work our way around, and gently with the tip, we're going to go in and try to remove that interproximal cement from the embrasure. He had that nice papilla hanging down between tooth number 8 and 9. You can see that's kind of saving us here. We've got some porcelain hanging out there to close that space, to close that huge space. And on no-prep veneers, you have to carry it straight out. If these were crowns we were prepping, that mesial area on both these teeth would be an area where I would drop those margins subgingival and get a more natural emergence profile. But for somebody who wants no preps, this is what we have to do. And thankfully, he had that papilla hanging down. Because when you have a space as large as the diastema that we had on this case, if you remember how large that was, it's possible you may not be able to close it all the way. You can probably close it all the way in the contact of the tooth, but it's going to be difficult to close it in the area of the gingival papilla. So that gingival embrasure might be open. And a lot of times going into these cases, as we did on this one, we tell the patient, we're going to try to close that space as much as possible, but we may only be able to close it 80 or 90%. And the patients usually realize that closing it 80 or 90% is better than leaving it open 100%, and oftentimes that's good enough. So we go into it with that kind of mindset, and if we get lucky and have some extra tissue hanging down like we do here, or a real big incisive papilla, or a facially ectopic placed incisive papilla, then we can get a good result like this. But we don't go into it telling the patient, yes, we can close that all the way, don't worry about it. This won't be a problem at all. So once I've gone in and clean out the interproximal area with our serrated strip and with the Glide Dental Floss, we'll go ahead and cure it more. Cure it all the way. And again, just check and make sure our contacts are free. And at the same time, we're looking to make sure that we don't have any excess cement bonded on either of the adjacent lateral incisors. That's a good way to make sure that your veneer will not go down into place. And until you get comfortable with this, I know dentists who will try on those lateral and cuspid veneers again just to make sure they will go down. Part of the reason for that is having contact issues. You know, if you really don't feel that you have good contacts, it can be problematic. And so once 8 and 9 are bonded into place, you know that they're not going to be moving around anymore. There are times when you try in 10 no-prep veneers, or even regular veneers for that matter, but certainly with the no-prep and minimal prep veneers, that you could have contact issues that you don't see. As you try in other veneers, adjacent veneers will move just slightly and lift off the tooth, and it'll look like they're all in place and they're all fine, but you may in fact end up with a contact problem when you start bonding them into place. So with those orange wood sticks that you see me use all the time, you can really get a feel for whether or not veneers have moved at all during the try-in phase. And if I notice that they do keep moving, I'll put on 8 and 9 as we've done here, and then try in 10 and 11 again and make sure we don't have a contact problem. A lot of times if you do have a contact problem, you can cheat it back to the bicuspids. And what I mean by that is you can put on 8 and 9 and they'll go to place fine. Then you can put on, for example, 10 and 11, as we're doing here, and they'll go to place fine. And then you won't notice it till you go back to the bicuspids that, okay, now you got to pay the price. Now the contact problem is really here, because there is a little degree of play in these veneers. And so by cheating the contact problems towards the posterior, you're able to do your adjustments on those veneers rather than in the anterior. You really don't want to have to touch teeth number 8 and 9, or even 7 and 10 for that matter. The cuspids is a little more acceptable, but you don't want to have to do a lot of changing. But really what it has taught me from making that mistake many times in the beginning is to use these orange wood sticks and really pay attention to whether or not these veneers are seated all the way when we're trying them in, and if when we try in adjacent veneers, other ones in the front seem to pop up. And you've probably had this happen where you put on, a cuspid and a first bicuspid and the lateral will move, and you push the lateral back down and then the cuspid moves. And those are those kind of contact problems that you need to know about ahead of time. There's my assistant putting the cement into the resin cement into one of the veneers and hand it to me on one of those sticky sticks. There's several manufacturers of those sticky sticks. Ivoclar makes them, Microbrush makes them. Really nice way to transfer veneers. If you try to transfer veneers by hand, too many times you'll get your finger into the cement on the inside. And you can see as I push down that orange wood stick, it seats farther, and then the lateral seats farther as well as I push it down into place as I'm staring at that cuspid to make sure that the veneer on the cuspid hasn't moved at all. And I'm putting a good amount of force there on the lateral. Now I come in with the cuspid, put some pressure on there, and she cures both of those. I want to make sure those are down. Again, with the minimal prep and the no prep veneers, the trickiest part about seating these is making sure that they're down all the way when you cure them. There's nothing worse than thinking they're down all the way, curing them, then cleaning off the excess cement at the facial and finding you've got a wide open facial margin. And I've made that mistake before a couple of times, and that's how I learned to hold them down while we were curing them, and to make sure during the try-in phase that they would go all the way down. Don't try to cheat. If you're putting one of these down, the veneers into place and holding it with the stick, and it just feels like when you push one, the other one pops up, and then if you push the other one, the first one pops up, you're going to have to make an adjustment. Or just put the first one in. If you don't like two moving targets, bond the first one in and then try the other one in and make your contact adjustments. I think it's really difficult to make contact adjustments with two loose veneers. Crowns, not a big deal, adjacent to each other because of the way they go down into place and sit once they're in place. But with veneers, just trying to hold them down to even check the contact with a piece of floss is tricky, let alone adjust those contacts on those two. Veneers are one of the times where you definitely want to bond it in first and then have one loose one single restoration to deal with contacts. And again, here in our split screen, you can see me putting the bicuspids down on the upper left-hand side, pushing them into place. A lot of times I'll use a cord packing instrument if I can't quite get in with the orange wood stick, and then we're placing the veneers over on the right-hand side as well. And this goes definitely quicker than it does when we place regular veneers. Since there's only enamel exposed and no dent and no need for a rubber dam, which I know a lot of dentists like, not having to place that. And there's my second favorite burr of all time, the 7408, being used to clean the resin cement off the lingual. Many times there is a little speed bump right where the porcelain comes together with the tooth on the lingual, so you can go in there and modify that as well and kind of carve that down. And so those 7408 burrs, in fact, I like them a little better when they are slightly dull. They almost cut kind of too much, and they'll almost cut tooth. And I like when they're slightly dull and they've been used to contour some other direct composites or composite inlays or onlays. And I like having old 7408s. It takes a lot for me to throw one of those away. I mean, it has to really be polishing by the time I'll throw it away. Here we are using that brownie wheel that you see me use so often on these veneer cases. Although if you wanted to use a one gloss wheel from Shofu, that would work fine as well. Any composite polishing wheel would probably work good. We're just trying to get the cured resin cement, since we're a little bit sloppy, and we always are, getting that off the porcelain without doing any damage to it. I've just always used the brownies and greenies, and I like what they do because they work so quick, and I can see the composite, the resin cement just disappear off the front of those veneers. Then we're going in with the greenies just to make sure we have all of that off. Again, this is probably a little bit of overkill on polishing these and getting them right, but I really like to, give it every chance of looking really nice. And I know it's probably not doing anything to polish the glazed porcelain, but it really does a nice job of cleaning them up and making them look really good. Now we check the occlusion on both sides. Usually on these bicuspid no preps, they hesitate to cross over that buccal cusp, and so the bicuspid no preps, you usually won't see anything in the occlusion because they usually won't wrap over that cusp. That would be something waiting to break. Interestingly, on the anterior, I can count the number of no prep, minimal prep veneers that I've had chip on the incisal edge on one hand, and that's out of hundreds and hundreds being placed. So take a look at that, and is it perfect? Well, the shape of the central incisors is not perfect, but the patient didn't come in and said, give me perfectly shaped central incisors. he said, close my space between my teeth. And look at that. For a no prep case, that is pretty darn decent. I know the patient was just totally happy with it, to have all their spaces eliminated without having to have any prepping, any shots, any temporaries. You know the whole drill along that. I really find these no prep veneers, I did not like them in the beginning. The more I do, the more I like them, and the more patients we offer them to, because they're so thrilled with them as well. And you can see how nice that looks. And, you know, when you look at no prep veneers, the thing you really want to look at besides the aesthetics is the gingival third. How does the gingival third look? Does it look big and bulky, or does it look like it's a natural tooth with good emergence profile? And you can see on most of those teeth, it looks pretty darn good, especially on the cuspids and the bicuspids. Really nice looking emergence profile there. And that really is a result of being able to get these veneers wafer thin, you know, down to 0.3 millimeters, and being able to make them so thin that we don't have to do any finishing at the gingival margin afterwards. That scares me. I don't want to put these veneers in and take a carbide or a diamond burr in and do any finishing at the gingival margins, because I'm never going to be able to polish that porcelain again, and I'm afraid of gouging the root surface as well. So we try to keep those as thin as we can in the gingival third, and having been placing these now for a number of years, I don't see any reaction to it. In fact, Dr. Gordon Christensen on his no prep veneer video talks about the same thing, how he has been surprised at how well the gingiva tolerates these types of restorations. I think when you do your first no prep case, pick a proper one where you've got spaces between the teeth, and I think when you see the patient's reaction and see that case a few months down the road, you'll know that you and the patient have made a good decision.